Good morning, all of you. Today I am going to talk about Unit 3 Clinical Optometry on Objective Refraction Retinoscopy. So I think all of you know retinoscopy. If you don't know, let me tell you in this lecture, it will be divided into two parts. First part will talk about the parts of retinoscopy, what is the objective of the retinoscopy, and also it will talk about the types of retinoscopy and how the two different types of retinoscopy is different. Okay. So once we finish that, then we will go to the procedures of retinoscopy, challenges of retinoscopy and the indications of retinoscopy, how to interpret the retinoscopic result. So the learning objective for this presentation is to learn the types of retinoscopy, to come the features of spot and streak retinoscopy. Those are the two basic types of retinoscopy we all know. That is the spot and the streak retinoscopy. And also to learn the parts of basics of optics of retinoscope. So these are the three things we will do in the first half. In the second presentation, we will learn about the different procedures of retinoscopy, how to do retinoscopy, and for different patients, how to do, what are the difficulties in retinoscopy, and how to interpret the results of the retinoscopy. So this. Now, before going into the definitions and all these things, we have to find out why I am giving this lecture as the first. In objective refraction, first of all thing, you have to understand what is the difference between objective and a subjective refraction. Objective refraction is a refraction where we can find out the refractive status of the eye without the cooperation of the patient. And it's a very important thing because there will be a lot of patients who may not respond to your answers or to your queries. For those patients, subjective is very difficult, and subjective is where patient cooperation is required. So objective is the refraction is a method where patient cooperation is not required. Subjective refraction is a refraction where patient's cooperation is required. Now, in our clinics, in our day-to-day clinics, a lot of our patients we will find out who will not respond to our queries or who will not respond to our test results. The cooperation which is required, we will not get. So in those cases, the objective method is very much important. That is why objective refraction is very important. In objective refraction, there are two types of procedures. One is retinoscopy, another is autorefractometer. Now, retinoscopy is very important because retinoscopy, the result which we get is much more authentic and much more valuable than autorefractometer, because we all know autorefractometer is a machine which does auto, from the name only you can understand autorefractometer. Automated refraction, it is done by the machine, and we all know machine may give us accurate result as well as sometimes it can give fault. But retinoscope is more of a manual method where individual refraction skills is required. So it's a little bit difficult, but once you master this technique, once you are very aware about this technique or you are very much comfortable with this technique, it will be bread and butter for you. Not only for you, for all the optometrists who are studying optometry, for them retinoscopy is very important. But nowadays, because of the automation and all these things, people, hospitals, optical shops, everybody prefer autorefractometer because of the digital and the computerization. But retinoscopy remains still the old fashioned and very important, because that is where you can show your optometry skills and technique, and you can be dead accurate with it, especially for pediatric patients. Last lecture, as I was telling you about the pediatric visual acuity, pediatric patients, especially with patients who cannot respond to your queries, patient who are specially abled patient, all those patients, the retinoscopy is very important. So now let's come to the point. What is the definition of retinoscopy? Retinoscopy is a clinical procedure for objectively measuring the refractive status of the eye. Another refraction method is autorefractometer. Now, retinoscopy projects light into the eye, and the characteristics of the reflected light is analyzed to estimate the refractive error. You can see the light from this source comes, hits over the mirror and goes into the eye, and from that it reflects back to the patient's eye and it reflects back to the examiner eye. So from there, when the light goes, the secondary source which is hitting the patient's eye, it is going reflecting back. That light is projected by the objective, means the examiner, and the examiner sees the light and try to understand what the refractive status is. So retinoscopy is basically projection of light onto the patient's eye. So here you can see the instrument is here. Light goes from the mirror to the patient's eye, and from the patient's eye it comes back and it goes to the objects. So the observer eye, an observer try to understand what type of refractive condition it is. If it is a myopia, then different types of refractive condition will be there. If it's hypermetropia, then it will be a different refractive condition. If it's emmetropia, then it will be different condition. So the parts of the retinoscopy, this is a typical, you can see here, streak retinoscopy, which we normally use. Other one is the spot retinoscopy. We will come and we will see, wow, what is the difference between spot and streak retinoscopy. We have got a light source, you can see here in the down. We have got a reflecting mirror, which reflects the mirror from the light, and you have got a peephole. From the peephole and the reflective mirror, light goes into the patient's eye, and from the patient's eye, it will reflect back to the observer eye, and we will try to find out what is the refractive status of the patient's eye. Okay. So there are two types of retinoscope, spot retinoscope and streak retinoscope. The spot retinoscope is used to find out the refractive status, and streak retinoscopy is used to find out the refractive status, but there is a difference. Which is difference? Spot retinoscopy is simple form of retinoscopy, but again, as I told you, anything which is simple will not give you an accurate results or will not be so much of give you a detailed result. But things which are complicated, like when I was teaching you Snellen chart and Logmar chart, I was telling you Snellen chart is normally very easy to use, but it's not so accurate. Similarly, the spot retinoscopy is also very easy to use, but it is not so accurate like streak retinoscopy. But streak retinoscopy, it's a little bit complicated, but not complicated, I will say. But if you can know how to use streak retinoscopy, then also streak retinoscopy is very useful. In spot retinoscopy, as you can see here, there is a light source over here, and external light source is required. And this light source makes the light fall over here in the streak. And from the streak, it goes to the patient's eye. And the examiner who is there, there is a small hole you can see. And from the hole, the patients try to see the examiner's eye. And there, the patient try to see the glow properly. So this is how a spot retinoscopy work. Okay, and one of the most important thing is the room should be absolutely dark. If the room is not absolutely dark, the light will not. The position of the light is very important. Position of the patient is very important. Position of the examiner is very important. If any of the three gets wrong, then the patients, you cannot focus the glow on the patients, and you cannot see the glow properly. So it's very important that you fix the light in the proper position. You have to fix yourself with the retinoscope in the proper position, so that the light reflecting from the back of the patient's head will come to your retinoscope, and from the retinoscope it will go to the patient's eye, and from the patient's eye you will try to understand what is the type of glow inside the patient's eye, and then only you will be able to understand. The one of the most important designs of spot and streak is, in the spot the retinal light is external, and in the streak you always need an external light source to perform this, and in streak the light is inside. We will come across. The name is due to the shape of the light coming out of the mirror, that is spot or round shape. Okay, in streak, the normally the streak is like a rectangle type of thing, but in a spot it is round. So it's a round shaped goal. Size of the people minimum is 4 mm. As I told you, in pinhole it's 1 mm, but here the people it's little bit big, so it is 4 mm. Mirror is plane mirror or weak concave mirror. So the mirror which we have in the streak retinoscopy is plane or concave mirror. What is the advantage? Cost, both meridian can be examined at the same point of time. Yes, spot retinoscopy, about 100-150 rupees Indian currency, you can get in any market. And both meridians can be examined at the same point of time. Disadvantage, portability, because you need an external source of light, which I told you. Without the external source of light, you cannot check the spot retinoscopy, because without the spot light always, and totally dark room is required. Without a dark room, you will not be able to understand the glow properly, and axis of the astigmatism cannot be well examined. Since it's a round type of shape, the axis of the glow cannot be well examined. So to understand the axis of the glow, you need to have the streak retinoscopy. Now coming to streak retinoscopy, as I told you before only, Streak, sorry, light coming out of this has a shape or a slit or a streak. So you have a slip or a streak which actually helps you to light to fall on the patient's eye, and with that patient eye you can see the glow properly. So light coming out of this has a shape of a slit or a streak. So if you, this streak looks like this, not like a round glow which you can see over here, and you have to move it. So you don't need an external source of light. Light is over here, and from that light the source will come and illuminate the patient's retina, and from that when the light will come back, you can see. So there are two glows you can see, one glow outside and one glow inside. These two glows will coincide with each other, and you can understand what is the status of the glow. So knowing the status of the glow is very important. So what are the advantages of streak retinoscopy? The advantages of streak retinoscopy is compact, small and portable. Light source is within the instrument. So the light source which is there, it is within. So you don't need an external light source. So you can use the retinoscopy whenever you want. And another important is it can be rotated 360-degree. The axis of the, since it's a rectangular slit type of axis, so you can rotate it 360 degrees. So astigmatic axis can be assessed easily. Both plane mirror and concave mirror options are available. So you can change the axis both in plane and concave mirror options, and it is available. So these are the parts of streak retinoscopy. Normally, this company is Killer. We also have got Hein, which can be used in rechargeable head. You can see here there are two batteries over there. This is the rheostat. This is the collar and sleeve. This is the peephole. This is the broadest, and this is the retinoscopic head. This retinoscopic head is very important. Collar and sleeve. This is the rheostat. This is the peephole, and this is the broadest from which we can see the rest properly, and peephole, so that you can put the light on the patient's eye, and you can change the collar or sleeve, and the rheostat you can understand. So with this rechargeable handle, you can find out what is a part of the retinoscopy. Uh, so you can put the light from here, recharge, and the light will reflect and go to the patient's eye and will come back, and you have to see the glow in the over there. So here what I told you is there are two types of glow. One is inside the retinal glow, uh, and outside the glow, which is from the instrument. One will come from the retinal glow. The blue light which you can see over here, this blue light will come from the patient's eye, and this blue light you will try to evaluate. So if the glow is within your moving with your direction, it will be considered as with movement. If it is considered as an opposite direction, it will be considered as against movement. If there are no glow, then it will be considered as no movement. So this is the part of the strict retinoscopy. This will mark the end of the my first part of retinoscopy, where we will just I have just explained you the basics of retinoscopy. Now in the next thing we will discuss about the, in the lecture 5 we will discuss about the objective refraction, about the, this is the next part of where we will talk about the, to explain what is retinoscopy, to learn the characteristics of retinoscopic reflex, to describe the optical principle behind retinoscopy, to explain the importance of working distance during retinoscopy, and also to learn the procedure to estimate refractive error using retinoscopy, and to describe the appropriate setup for performing retinoscopy, and to learn the documentation and analysis of retinoscopic results. So what is retinoscopy? As I already told you, to objectively estimate a patient's refractive error, to estimate refractive error for a patient who cannot communicate. As I told you, retinoscopy is very much important for special patients, though, like babies or young children, mental or physical disability, deaf or mute people, people who speaks unknown languages. So objectively getting the refractive error is very much important. So the main function of the retinoscopy is the patient light from the retinoscope gets reflected from the patient's retina and illuminates the pupil. And when it illuminates the pupil, you have to, as I told you, there are two types of glow over here. You can see one glow is from the machine glow, the retinoscopic glow, and one which will reflected back, that is the retinoscopic glow. And this retinoscopic glow, when it will come back, we have to evaluate. And this is when it will move in the same direction, we normally call as with movement. When it will move in the opposite direction, we will call it against movement. When there will be no movement, it will normally known as neutral. So move the retinoscopic light across the patient's pupil. Reflex movement differs with the refractive status. So neutralize this movement using trial lens. So we will try to neutralize this movement using the trial lenses. Okay, the trial lenses which I talked about. So first of all thing we have to understand, before understanding the retinoscopy, we have to understand certain points. One point I already told you, that is nodal point while teaching the Snell lens chart. That is, whenever there is a nodal point located on the lens, considered as the center of the eye. And the far point is the farthest point at which objects can be seen clearly when the eye is not accommodating. So what is far point? It is the farthest point at which an object can be seen clearly when the eye is not accommodating. That is known as far point. So one is emmetropes at infinity, myopes at a finite distance in front of the eye, hyperopes at a virtual point behind the patient's retina. So the actually what we do in retinoscopy, in the next slide I will talk about the uh, principle of retinoscopy, but before going it, we need to know the far point. And in, as I told you, there can be three types of movement. Three types of movement will distinguish about the three refractive conditions, that is the emmetropes, myopes and hyperopes. At emmetropes, the far point is at infinity, myopes at a finite distance, and hyperopes at a virtual point. And nodal point is the center of the eye. Okay. Now we will talk about the optics of the retinoscopy, which is very important. Now, optics of the retinoscopy, why I was talking about the far point, because it deals with the far point of the eye. So what is optics? Let me read it out for you. When the far point of patient's eye corresponds to the nodal point of observer eye, the neutrality or end point occurs. So my main question will be to coincide the far point of the patient eye with the nodal point of my eye. Suppose I am the observer. So what I will try to is, I will try to coincide the patient's far point with the nodal point of my eye by using the lens. When I will see it is not coinciding, if it is coinciding, then there will be no movement. That means it's neutralized. But if it is not coinciding, then I have to use the trial lens and I will try to coincide. If it is in front, I will bring it behind. If it is behind, I will bring it in front. So the far point of the patient eye should match with the observer's nodal point, then only the endpoint will occur. That is the optics of the retinoscopy. I think, hope all of you that the concept is clear by this time. So there are three stages of retinoscopy. First of all stage is the illumination stage. Illumination stage, light from the retinoscopy illuminates as a patch of the retina. Next is the reflex stage. The light rays get reflected from the retina and form an image at the far point of the eye. So the light from the retinoscopy illuminates a patch of the retina. So whenever I told you, whenever the light goes, it goes and hits the retina of the patients and it illuminates. So that is the illumination stage. Next, when the light will come back to you, it is normally known as reflex stage. So the light rays get reflected from the retina, form an image at the far point of the eye. So when the light will come back, we will consider it as reflection stage. And projection stage, when we are projecting this ray, reflected ray gets projected onto the patient's retina. At this stage, the examiner can see the reflex. So whenever we can see the reflex, see the retinoscopic reflex properly, whenever the light will come back. So using the trial lenses, we project the far point patient's eye onto the examiner's nodal point. So by using the trial lens, as I told you, putting the trial lenses in front of the eye, we coincide the far point with the uh, nodal point of the patient's eye. So assume that is done with the plane mirror. The width movement will consider three refractive errors. So whenever with movement, normally the students make a mistake that it is hypermetropia, but it is not. With movement will consider three movements: emmetropia, hypermetropia, myopia less than the working distance. Against movement will consider myopia more than the working distance power. So there are three types of movement with movement: emmetropia, hypermetropia, myopia less than the working distance. Against movement will be myopia more than the working distance. So we have to find out which refractive error we are having, and with that we have to understand with and against movement. With movement will consider emmetropia, hypermetropia and myopia less than the working distance. Against movement will consider myopia more than the working distance. Brightness, is it bright or dull? Reflex get brighter as you get closer to the neutral point. Speed, is it fast or slow? So if the brightness is more, we know we are close to the neutrality. If it faster, we are close to the neutrality. If it is slow, then we will understand it is less. And thickness, if it's wider or narrow, If the retinoscopic reflex becomes wider, then we will know it's close to the neutrality. So three things we normally check in a globe: brightness, speed, and thickness. If it is brighter, then we know we are close to the neutrality. If it is faster, then we know we are close to the neutrality. And if it is wider, then we will know we are close to the neutrality. So here you can see the three pictures: narrow and dull, more refractive error. This you can see same, and wide reflects wider and brighter, very close to the neutrality. So whenever it is getting wider and bigger and brighter, we know we are close. If it is dull and it is very small, then you will understand that we are very far. We have to use more lens. But if we are using, if it is getting brighter and darker, then we can consider as the big lens. Meridian is the movement same in all directions. So whether in 90 degree, in 45 degree, in 180 degree, in 135 degree, whether in all the degrees, whether the meridian is equal, is same or not, we have to find out. In 90 degree, 145 degree, 180 degree, 135 degree, is the meridian movement is same or not? If it is not there, then there is a chance of astigmatism being developed. So we have to understand whether there is an astigmatism or not. If there is break, then we will consider as astigmatism. If there is no break, then we will consider as normal spherical refractive error. So streak and retinoscopic reflex are only alignment at 45 degree and 135 degree. So it is only aligned at 30 and 145 and 135. Other than that, there is a break. So there can be a chance of astigmatism. I'm not going into the details of astigmatism in this lecture. Maybe in the next lecture, we will discuss about astigmatism. If there is a break, then we will try to align it and we will try to find out the axis. Now I will talk about the working distance. From which distance we perform the retinoscopy. You can see here a doctor is performing retinoscopy on patient side and he is holding the hand like this. Why can you tell me? Because we normally practice optometrist practice retinoscopy from one hand distance, which is known as working distance. Why? But why we use this one hand distance? Why we don't do it from very far? I will tell you. Optical infinity is considered from 6 cm. Ideal distance to perform refraction is at infinity, which is not practical. So ideally we should do from very far, which is at the infinity, which is not practical. Hence we need to compensate that in the refraction. So we need to compensate in the refraction. Importance of maintaining working distance. So we have to maintain the working distance, and that maintaining of working distance is very much essential. Because we are not 6 mm or far away from the person, we must compensate our working distance by deducting the working distance power from the neutralizing lens power. Suppose we have a power, we have to consider as, suppose we cannot do it from 6 meter distance, but our working distance is one hand distance, which is 67.5, right? So from 67.5 we are getting the power that is normally known as gross retinoscopy. But after deducting the power of the working distance, the power which we will get is normally known as net retinoscopy. The calculation I will teach you in the practical classes. How we are doing, normally 67 by 100, it will come 1.5. So if we deduct 1.5 from 2, you will get plus 0.5. So this calculation I will teach you in the practical. But for now, now just remember, gross retinoscopy plus working distance lens is considered as total retinoscopy plus working distance power considered as gross retinoscopy. After deducting the working distance power, we normally consider as net retinoscopy. Okay, so this is very much important. So strict retinoscopy methods. Now, what is the method of? Both the examiner and the patient needs to be seated face to face with each other. Examination to be conducted in a dim room. In a dim dark room you have to conduct. Ask the patient to look at a fixation target at least 3 meters away. So 3 meters away the patient is looking. This is to relax the accommodation of the patient. This also helps to maintain steady fixation. Accommodation can also be relaxed by keeping a convex lens of 1.5 or 2 in front of the non-scoping eye. You can also ask the patient either to look very far away to relax the accommodation, or the eye which you are not doing, you can put high plus lens of 1.5 or 2 diopter so that the patient accommodation is relaxed. To perform retinoscopy as close to the visual axis of the patient's eye as possible. So the examiner's eye should be at the same height of the patient's eye and maintain the working distance. So if we can maintain the working distance, it is good. So we have to find out where the performing retinoscopy as close to the visual axis of the patient's eye as possible. Examiner eye should be at the same height of the patient's eye and maintain the working distance. Performing retinoscopy at a wrong working distance, example 50 centimeter or deducting 1.5, can cause problems. So these are the common errors which normally we do while performing the retinoscopy. We are doing from 50 centimeter, but we are deducting 1.5. 50 centimeter is how much? The formula I told you, it's 2 diopter. So for 50 centimeter, we need to deduct 2, but we are deducting 1.5. So if we are deducting 1.5, then it's not correct, then the power will come wrong. So performing at off axis, I told you the patient should be aligned with your alignment. If it is not aligned with your alignment, then the power will come here and there. So to align the thing properly, you need to sit straight in front of the patient and same axis needs to be performed. Until and unless you are not doing the axis in the straight form, then their off axis refraction can be there. Blocking the patient's view of the distance chart stimulates accommodation. If you are blocking, suppose when we are doing the retinoscopy, we are so much focused about seeing the glow that we block the patient's other eye view. So if we are blocking the view, then the accommodation will stimulate, it will stimulate, and as a result, the patient will not be able to see properly. Confusing the retinoscope collar position, plano and concave mirror position, and then we can see the properly. So we have to perform off-axis refraction, so we cannot block it and we need to check the things properly. So retinoscopy, as I told you, is a very important thing. Now I will take little bit of your time of understanding this cross, as I told you, because there are different working distance. Okay, now the working distance, when we, especially when we are performing for one hand distance, normally for Indian, whenever we are doing one hand distance working, it is considered as 67 or 67.5. Whenever we are taking for 75 meters, some people may have a long working distance, they are doing from 75, for them it's okay. Maybe from 1 meter some people prefer to do. For their working distance, the lens will be different. For 50 meter, the work distance and lens will be different. So we have to understand, measure from which distance we are doing. From girls normally have a small hand. So if they are doing from 50 centimeter, then we have to deduct plus 2 from there. Boys normally have a big hand. So normally 67.5 is the normal. If it is somebody is doing from 75, so you have to divide it and find the power accordingly. Okay. Second of all thing, whenever you are doing it from 1 meter, it will be 1 diopter. So you have to find out which one is your power, whether it's 1.25, whether it's 1.5, 1.75 or 2. Accordingly, you have to deduct from the gross retinoscopy. Gross retinoscopy is the total power which you are getting. And net retinoscopy is the power after deducting the working distance lens, the power which you are getting. Another thing what you have to remember, in some schools and some colleges, they teach you to do retinoscopy, putting the working distance lens on the trial film, which is also okay. You can do it. You can do by gross and net retinoscopy, or also you can do by lens form, which is calculating the working distance, putting 1.5 or 1.75, whichever is your working distance, and doing it, doing the power. And after doing the power, you just remove the working distance lens, which is also fine. There is no problem, you can do it. But most importantly, when we are doing the retinoscopy, this slide is very important. As I told you, that the common error, one of the most common error is your changing of working distance, which is not mentioned in the slide. Is normally we start with 1.67.5 while doing the glow. If especially when you have a high power, you normally go very close to the patient. So whenever you go close to the patient, suppose you started with 1.5, but now you are going to 2, and finally when you cut out the power, it's 2, but you are deducting 1.5. There only you get a mistake of 0.5 or 1. So you have to check whether you are doing it from the proper distance or not. So if you are doing it from the proper distance, 1.5, you are using 67.5 only, then it's fine. But if you are doing from 67.5, but you are going close or going far away, then your refractive error will be problem. So maintaining the distance is one of the major thing for retinoscopy. Another thing is with the pseudo power, because sometimes what happens, as I told you, with the characteristics of the glow, whenever the refractive error is very high, you get a dull glow and very dim glow. So what happens if you put a high power thing? The students, especially whenever they do perform the retinoscopy, they cannot see properly. So they say that it's neutral, but it's not neutral. The refractive error may be uh, -5 or -6, because since the glow is so dull and so less bright that it looks like it's neutral. But suddenly when you put -2, you will see an against movement. So what happens is, you have to see the glow, you have to understand the glow very comfortable, minutely. Then only you will understand about pseudo neutrality. and normal neutrality, because normally you will say that it's a pseudo neutral, but it's not a pseudo neutral. You have to find out where the problem is. Until and unless you don't find out where the problem is, what is the movement, you will not be, you have to, for that you have to see lot and lot of patients. So until and unless you don't see a lot of patients, you will not be able to understand about the pseudo neutrality and the actual neutrality, because most of the patients will say that it is neutral, but actually in real case it will not be neutral, and you will find as the pseudo neutral. You end up in pseudo neutrality and the entire retinoscopy is wrong. Suppose the patient is having a -5 but you are giving 0, and when you are doing the subjective you find there is a total mismatch between the subjective and the objective. So these are the points which I want to tell you. So these are my, this is the first part of unit 3 of retinoscopy, which deals with the basics. In the next lecture I will tell you about the details of retinoscopic, especially cylindrical correction for children and other thing. In the next class I will take you. Thank you.